pleasure to co-chair this session with Professor Manal Mawad and Professor Ahmed Selim. And the session deals with rectal cancer. The first presentation in this session is titled Non-Surgical Management of Rectal Cancer. The presenter is Professor Fadi Gira. Professor Fadi Gira is Professor and Chairman of the Department of Radiation Oncology and Director of the American University Beirut Medical Center. Please, Dr. Fadi.
Thank you very much, Mr. Chairman, and thank you also to the audience for being courageous and staying late for the talks. I will be very brief and I will not exceed my time. The title is there's something here coming up. Okay, title is on non-surgical management of rectal cancer, and actually during the talk I will be discussing some conservative management of rectal cancer rather than only non-surgical. So we will see the purpose of this talk is actually to challenge the existing paradigm or algorithm of managing rectal cancer by preoperative chemoradiation followed by standard surgery. And I will share with you some of the data in this topic. So first, this is the outline of the talk, and we'll discuss, as I said, the non-surgical approach, the definition of clinical complete response, which is very challenging in the clinic, the minimal surgical resections, which, as I said, this is a part of the minimizing or de-escalation of the surgical approach in rectal cancer, and I will then talk briefly about some current trials that address these aspects. First, let's state the obvious or state the evidence on optimal preoperative chemotherapy and radiation therapy for rectal cancer. Everybody knows in the room or should know that the radiation therapy, when it's given preoperatively, is about 45 to 50 gray. This is what we call the protracted course, and the standard is with capecitabine chemotherapy. Adding oxaliplatin does not improve outcome, and here the references, this is not the topic, I will not elaborate on this. Now with this treatment, the response after this treatment, it leads to downstaging in about 60 to 70% of the cases, which means of 100 patients, you have about 2/3 of them will have a smaller tumor that's easier to operate on. With that, also you have complete clinical response in about 40%. Some people say more, but it's usually about 40-45%. This is complete clinical response, not pathologic, clinical, which means it's not visible, not touchable, not palpable. And of those, half will have a complete pathologic response after you take the specimen out and you send it to the pathology. So how to assess clinical response? And this is a challenge. If you want to de-escalate, if you want to do less surgery, if you want to do less wider surgery, then you have to know who are the patients who could benefit from it. Because we just saw not every patient is going to respond. Only about 2/3 of them will respond, and only about 40% will have clinical complete response. But how to define clinical response? This is a challenge. First, it's simple. You can start by doing a digital rectal examination, and you can do something very simple also, relatively simple, is sigmoidoscopy. But the most important test could be coming from radiology, which is endoscopic ultrasound, MRI, and PET scanning. We will see in a minute that these are actually very promising tests, but unfortunately will not help you a lot in determining the existence of a clinical complete response. Please have to differentiate between clinical complete response and pathologic complete response. This table is a summary of many publications on the topic of imaging to determine the clinical complete response or clinical response after chemoradiation. On top, it's the endoscopic ultrasound, and you can see, I want you to only look at this last one. This is negative predictive value, which means if the test is negative, it truly means that there is no disease. So 74%, so you have about 25%, 1/4 of the patients are missed by EUS. MRI misses about 15%, and the best test is PET scanning, it's about 93%. It's very good, but it's not 100%. Obviously, a radiology cannot be 100%. The only test that can be 100% is obviously pathology, but here we are trying to do before pathology to predict the pathologic complete response based on imaging. So, in summary, the imaging, the best of the imaging is PET scanning, but this is not enough to determine the status of pathologic complete response. If you combine clinical, which means DRE and endoscopy, you have almost a good 80%. So clinical is almost as good as imaging studies. So this is to say that predicting pathologic complete response is not easy, and there is no straightforward formula to say this patient will have pathologic complete response, therefore leave him alone, don't do surgery or do small surgery. We cannot do it with the present technology. We cannot predict the rate of pathologic response, complete response. This is a very interesting study from the Cleveland Clinic, which correlated the clinical picture to pathologic response. It's very important. I want to go over it. This is the patients who had completely nothing on endoscopy, on digital rectal exam, and the red is truly complete response after resection of the specimen, and the blue residual disease. So even though patients have complete clinical response, some of them will have residual disease and depth below the mucosa. Here it's the presence of ulcer. So even if you have an ulcer, some of the ulcers actually had complete response patients. So this is not truly predictive. Ulcer doesn't mean always disease. And if you have a polyp, it's more residual disease. If you have a nodule, it's always disease. So this is a very interesting study to correlate between the endoscopic features and the pathologic response, which unfortunately cannot again correlate one-to-one. But obviously if you have a complete clinical response, you have a higher rates of complete pathologic response, but it's not one-to-one again. Now there are some criteria that were developed by experts in the field, and this is one from Brazil. And Brazil is a very important country where this concept of non-operative therapy has been developed, and this is by the group of Haber Gamma. And the criteria says non-visible tumor or whitening of the mucosa with or without telangiectasia, and no nodules, no deep ulceration, no stenosis. So all of this has to be together to indicate a complete clinical response by the criteria of this group. Many people are using actually this criteria to call a complete response, a complete clinical response present or not. Now, another factor that affects the response to therapy is the timing at which you determine this response. We know now that when we wait longer time after chemoradiation, you have higher downstaging. This is from the Royal Marsden group, where they studied patients after chemoradiation 6 weeks, 6 to 8 weeks, or more than 8 weeks. Look at the downstaging percentages here. When you hit more than 8 weeks, you have 62% of the patients significantly downstage. Obviously here they correlated also with the need for transfusion, the difficulties of operating, but this is another topic. So you wait longer, you have longer and better, you have better downstaging. And this is an important fact that the French have decided to study in a randomized fashion after completing chemoradiation preoperatively to operate after 7 weeks or 11 weeks. The trial question is only to look at 7 weeks versus 11 weeks, because they believe if we wait 11 weeks, we will be able to get a better downstaging and a better rate of complete responses in the tumor. So this is to be followed and to be seen. Again, this is we're talking about about clinical responses, not pathologic responses. When we come to pathologic responses, there is a grading system. This is a tumor regression grading system, TRG1, complete pathologic response, and TRG5, absence of response. Anything in between, few residual cells, fibrosis mainly, or residual cancer mainly, you have a grade from 1 to 5. And this is very important because people who are now using smaller amount or smaller types of surgery, they have to rely on this grading to decide whether to complete the surgery with the radical conventional surgery or to leave the patient alone, and we'll talk about it in a minute. So what is that we're going to talk about today here is conservative surgery after chemoradiation, and not the conventional radical surgery, not the conventional low anterior resection or APR. It's just minimal surgery or non-operative approach, no surgery at all. And we have some data and literature that are very important, that it's worth studying to consider in some selected patients. So this is the first study is on minimal surgery after chemoradiation. This is a well-designed and well-conducted phase 2 trial study from Italy, from the University of Padova in Italy. 63 patients were treated for T3N1 or T2 disease requiring APR, very low T2. And those patients received chemotherapy, radiation therapy, the usual. And 5 weeks later, if they achieved major CR, they were taken to a smaller type of surgery, either TEM or transanal endoscopic microsurgery, or FTLE, or which means full thickness local excision. Those patients, 63 patients, they had about 27% of complications after this microsurgery. So it was not easy. Those complications are diverse types. They're not all very bad complications. They were not all grade 3 and 4. They were all types of complications. And they found after local excision that the grade 1, which is complete pathologic response, or 2, few microscopic residual cells, about 70%, 68%. But about 1/3 of the patients still had and harbor 3 to 5 grade of response, which means that even in the face of major clinical response or major clinical response, you still have about 1/3 of non-responsive tumor by pathology criteria. Positive margins were 6%. Now, this protocol called for patients who had TRG 3 to 5 to convert them to a radical surgery, to complete the surgery. And some of the patients did not accept that. This is the design. I don't think you can see it from the back, but some of the patients did not accept that, and they said, okay, I had my surgery, I don't want to go and do more surgery. And those patients are here. If you don't see it, I will tell you that about 11 of them, when they were followed for several months, and actually about 3 years median follow-up, not all of them developed recurrences. So those patients had bad responses. They had local excision alone, no radical surgery, and yet they did not develop local recurrences. And this is an important point that need to be considered and kept in mind when dealing with post-operative chemoradiation patients. So not all of those bad actors develop local recurrence. This is a graphic presentation with the local control at 96% at 3 years for the entire cohort. Now, this is another study from Germany it's actually a compilation of studies, 7 studies of over 237 patients, similar type of management, minimal surgery after chemotherapy and radiation therapy for patients who had very good response. And these are the rates of complete response, and this is local recurrence, 0 to 4%, minimal residual disease, 0 to 6%, T2 stage, 6 to 13%, and obviously when you hit T3, which means that you still have disease going beyond the muscularis, you have about 10 to 40% local relapses. So this is very important to keep in mind. This technology, or this technique, or this approach, I should say, should be reserved for patients who have very good clinical response, and those who on pathology have a very good pathologic response. Otherwise, they should be converted to completeness or radical surgery, as we see. as we saw. This is a trial with minimal surgery that is being developed in the Netherlands. It's exactly like what the Italians have done. They would do, you don't have to read this, just in summary, chemoradiation, and those who had good response, they are randomized to radical surgery or a minimal surgery, which is local excision. And this trial is still ongoing and will probably answer some of the questions in this topic. There are other trials in France, in Poland, and Spain, and the only randomized that's actually a very interesting question is the French trial, which they are randomizing patients to chemoradiation 6 to 8 weeks for tumor that remain less than 2 centimeters, are randomized to TME, which is total mesorectal excision versus local excision. And this is a randomized phase 3 study. We'll probably again look into this and tell us more if those patients could be offered minimal surgery rather than radical surgery. Now, what about the non-operative approach? No surgery at all. You just wait and see those patients. And there are some trials, and the pioneer in this area is Dr. Angelita Haber-Gama, who is a surgical oncologist from Brazil, who published extensively in this topic. And this is the latest publication from her group. 183 patients, clinical T224 or node positive. They all received chemoradiation, the usual 8 weeks evaluation, and then those patients were observed if they had clinical complete response. About 50% of them had clinical complete response, and they were only observed. So what happened to those observed? 69% remained locally controlled, no recurrences. 24% developed recurrence and had a successful salvage, and 7% were lost because they had recurrences and they were not able to salvage them with additional surgery. So of 100 patients, about 7% are lost because of non-surgical therapy up front. So we have to keep this in mind. This is actually a high-risk type of management. Patients have to be aware that they are not having the standard of therapy and that about few percent of them will actually lose their life because they develop local recurrences. Now, what is the rate of local recurrences despite surgery in usual patients is usually less than 5%. So we are actually in the same ballpark here that it is, but patients need to know that there is a risk and they have to be aware of that. This is a case from her publication. This is a tumor. This is in a whitish mucosa, completely flat. This is considered a complete clinical response by her criteria. There's also a study from the Memorial Sloan Kettering where they actually looked at 32 patients with clinical complete response, and they followed them up without treatment, without any additional surgery. 81% remained locally controlled, 19% had local recurrence, but they were salvaged, and of those 6 was local recurrences, and some they had the distant metastasis. The local control rate in the Memorial cohort is, or not cohort, study is about 100%. So 93% in the Brazilian and 100% in the Memorial. So pretty much good numbers, but obviously those patients were followed very carefully. And finally, there is those experts who are dealing with this type of management. They met last year in Lisbon and they issued the statement. They call it the Lisbon Accord. The caring physician has an ethical duty to share with the patient suspected of a complete response the new choice of delaying the surgery and entering a specialist surveillance program, which means they are encouraging patients to consider, or physicians to discuss with their physicians, their options of observation rather than going with radical surgery. There are currently a couple of trials, one in the Royal Marsden in England. They are testing this non-operative approach, and one in Denmark, the one in England using MRI, here using EUS for surveillance. And in summary, patients with locally advanced rectal cancer who develop a clinical complete response to chemoradiation may have a possibility of conservative management, and this is something to keep in mind. Clinical complete response remains a clinical and endoscopic assessment, as imaging studies, as we saw in the beginning of the presentation, are not sufficiently powered to detect tumor macroscopic response, unfortunately, so we have to rely on endoscopic appearance and the softness of the area by endoscopy and by digital rectal exam. Need to keep in mind that a non-operative approach should be reserved for clinical complete responders only. while those with minimal residual disease could be offered local surgery like microsurgery or full thickness resection. Both should be applied for node negative. Obviously, we have to state the obvious. When you image the pelvis and if you have lymph node, this principle does not apply anymore. So we have always to make sure those patients have imaging node negative disease. And finally, current clinical trials will help refine some of our knowledge in this area and hopefully duplicate existing data, as most of it comes from single institutional report. Thank you very much for your attention.
Thank you very much, Professor Dr. Gira, for your very clear presentation about the non-surgical management of rectal cancer.